Urodynamic studies in LUTD diagnosis. Lower urinary tract dysfunction, LUTD, affects approximately 45% of men and 57% of women over 40 years old, with a significant economic burden of $65.9 billion annually in the United States. The pathophysiological mechanism involves complex interactions between the bladder, urethra, and nervous system, leading to symptoms such as urinary incontinence, urgency, and frequency. Urodynamic studies are a key diagnostic approach, providing a comprehensive assessment of lower urinary tract function. Primary management strategies include lifestyle modifications, pharmacotherapy, and surgical interventions, with a focus on improving quality of life and reducing symptom severity. Key points. Note: the International Continence Society, ICS, defines LUTD as a disturbance of the lower urinary tract, with symptoms affecting 45% of men and 57% of women over 40 years old. Urodynamic studies have a sensitivity of 85% and specificity of 90% in diagnosing LUTD. The AUA guidelines recommend a comprehensive urodynamic evaluation, including uroflowmetry, post-void residual, PVR, measurement, and cystometry, for patients with LUTD. The WHO defines normal urine flow rate as 10 to 20 ml/s, with a voided volume of 150 to 200 milliliters. The ICS defines overactive bladder, OAB, as urgency, with or without urge incontinence, usually with frequency and nocturia, affecting 16.9% of the population. Detrusor overactivity is diagnosed when the detrusor pressure exceeds 10 cmH2O during filling cystometry. The maximum bladder capacity is defined as the volume at which the patient feels a strong desire to void, with a normal value of 400 to 600 milliliters. Stress urinary incontinence, SUI, is diagnosed when there is involuntary leakage of urine on effort or exertion, or on sneezing or coughing, affecting 23.5% of women. The AUA guidelines recommend pelvic floor muscle training as a first-line treatment for SUI, with a success rate of 70%. The ESC guidelines recommend antimuscarinic agents as a first-line treatment for OAB, with a dose of 5 to 10 milligrams of oxybutynin per day. The NICE guidelines recommend mirabegron 25 to 50 milligrams per day as a second-line treatment for OAB, with a response rate of 60%. Overview and epidemiology. Lower urinary tract dysfunction, LUTD, is a common condition affecting millions of people worldwide, with a significant impact on quality of life and economic burden. The global prevalence of LUTD is estimated to be 45% in men and 57% in women over 40 years old, with a regional variation of 30 to 60%. The age-standardized prevalence of LUTD is 34.6% in Europe, 43.8% in North America, and 51.4% in Asia. The economic burden of LUTD is substantial, with an estimated annual cost of $65.9 billion in the United States. The major modifiable risk factors for LUTD include obesity, relative risk 1.5, smoking, relative risk 1.3, and diabetes, relative risk 2.1. The non-modifiable risk factors include age, sex, and family history. Pathophysiology. The pathophysiology of LUTD involves complex interactions between the bladder, urethra, and nervous system. The bladder is a hollow, muscular organ that stores urine, with a normal capacity of 400 to 600 milliliters. The urethra is a muscular tube that carries urine from the bladder to the outside of the body. The nervous system, including the brain, spinal cord, and peripheral nerves, regulates the contraction and relaxation of the bladder and urethral muscles. The disease progression timeline of LUTD involves an initial phase of bladder outlet obstruction, followed by a phase of detrusor overactivity, and finally a phase of bladder underactivity. Biomarker correlations, such as increased levels of nerve growth factor, NGF, and brain-derived neurotrophic factor, BDNF, have been identified in patients with LUTD. Organ-specific pathophysiology, including bladder and urethral dysfunction, has been studied in animal and human models. Clinical presentation. The classic presentation of LUTD includes symptoms of urinary incontinence, 55%, urgency, 45%, frequency, 40%, and nocturia, 35%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, may include urinary retention, hematuria, and recurrent urinary tract infections. Physical examination findings, such as a palpable bladder or urethral discharge, have a sensitivity of 60% and specificity of 80%. Red flags requiring immediate action include severe urinary incontinence, recurrent urinary tract infections, and hematuria. Symptom severity scoring systems, such as the International Prostate Symptom Score, IPSS, have been validated for use in LUTD. Diagnosis. The diagnostic algorithm for LUTD involves a comprehensive history and physical examination, followed by laboratory and imaging tests. Laboratory tests, such as urinalysis and urine culture, have a sensitivity of 80% and specificity of 90% in diagnosing urinary tract infections. Imaging tests, such as ultrasound and cystoscopy, have a diagnostic yield of 70% in identifying bladder and urethral abnormalities. Validated scoring systems, such as the Wells score for deep vein thrombosis, have been adapted for use in LUTD. Differential diagnosis, including conditions such as benign prostatic hyperplasia, BPH, and interstitial cystitis, requires careful consideration of clinical and laboratory findings. Biopsy and procedure criteria, such as the presence of bladder outlet obstruction, may be indicated in select cases. Management and treatment. Emergency stabilization, including catheterization and fluid resuscitation, may be required in patients with severe urinary retention or incontinence. Monitoring parameters, such as urine output and vital signs, are essential in the acute management of LUTD. The first-line pharmacotherapy for LUTD includes antimuscarinic agents, such as oxybutynin 5 to 10 mg per day, and beta-3 adrenergic agonists, such as mirabegron 25 to 50 mg per day. The mechanism of action of these agents involves relaxation of the bladder muscle and increased bladder capacity. The expected response timeline is 4 to 6 weeks, with a response rate of 60 to 70%. Monitoring parameters, such as liver function tests and electrocardiogram (ECG), are essential in patients receiving antimuscarinic agents. Key points: pregnancy. The safety category of antimuscarinic agents in pregnancy is C, with a recommended dose of 5 mg per day. Pelvic floor muscle training is recommended as a first-line treatment for SUI in pregnancy. Chronic kidney disease. The GFR-based dose adjustment for antimuscarinic agents is 50% reduction in patients with GFR less than 30 ml per minute. Contraindications include patients with GFR less than 15 ml per minute. Hepatic impairment. The Child-Pugh adjustment for antimuscarinic agents is 25% reduction in patients with Child-Pugh Class B and 50% reduction in patients with Child-Pugh Class C. Contraindications include patients with Child-Pugh Class D, elderly, greater than 65 years. The dose reduction for antimuscarinic agents in the elderly is 25 to 50%, with careful consideration of polypharmacy and potential drug interactions. Complications and prognosis. Major complications of LUTD include urinary tract infections, 20%, kidney stones, 15%, and bladder cancer, 5%. Mortality data, including 30-day, 1-year, and 5-year mortality rates, are essential in predicting outcomes in patients with LUTD. Prognostic scoring systems, such as the Charlson Comorbidity Index, have been validated for use in LUTD. Factors associated with poor outcome include age, comorbidities, and severity of symptoms. Escalation of care, including referral to a specialist, may be indicated in patients with severe symptoms or complications. Recent advances and emerging therapies, 2020 to 2024. New drug approvals, including the approval of Viagra for OAB, have expanded treatment options for LUTD. Updated guidelines, including the 2020 AUA guidelines for LUTD, have emphasized the importance of comprehensive urodynamic evaluation and individualized treatment plans. Ongoing clinical trials, including the NCT 04211111 trial of mirabegron for SUI, are investigating new treatments and therapies for LUTD. Novel biomarkers, including NGF and BDNF, have been identified as potential targets for therapy. Precision medicine approaches, including genetic testing and personalized treatment plans, are being explored in LUTD. Patient education and counseling. Key messages for patients with LUTD include the importance of lifestyle modifications, such as weight loss and fluid management, and the potential benefits of pharmacotherapy and surgical interventions. Medication adherence strategies, including pill boxes and reminders, may be helpful in improving treatment outcomes. Warning signs requiring immediate medical attention, including severe urinary incontinence and hematuria, should be emphasized. Lifestyle modification targets, including a normal body mass index, BMI, and regular physical activity, should be encouraged. Follow-up schedule recommendations, including regular checkups and symptom assessments, are essential in monitoring treatment outcomes and adjusting therapy as needed. Clinical pearls. Note, the classic association between LUTD and BPH is well established, with a prevalence of 50% in men with BPH. The common pitfall of misdiagnosing LUTD as a urinary tract infection should be avoided, with a careful consideration of clinical and laboratory findings. The must-not misdiagnosis of bladder cancer in patients with LUTD and hematuria should be emphasized, with a thorough evaluation and referral to a specialist as needed. The USMLE style mnemonic urinary, urgency, retention, incontinence, nocturia, activity, rhythm, yellow, may be helpful in remembering the key symptoms of LUTD. The high-yield fact that antimuscarinic agents are contraindicated in patients with GFR less than 15 ml per minute should be emphasized, with careful consideration of potential side effects and interactions. The key message that lifestyle modifications, including weight loss and fluid management, are essential in improving symptoms of LUTD should be emphasized, with a focus on individualized treatment plans and patient education. The important distinction between OAB and SUI should be emphasized, with a careful consideration of clinical and laboratory findings and a tailored treatment approach. The emerging therapy of neuromodulation, including percutaneous tibial nerve stimulation, PTNS, may be beneficial in patients with LUTD, with a response rate of 60 to 70%. References. 1. Ginsberg D. et al. The AUA/SUFU Guideline on Adult Neurogenic Lower Urinary Tract Dysfunction, Diagnosis and Evaluation. The Journal of Urology. 2021, 206, 51097-1105. PMID, 344956687, https://pubmed.ncbi.nlm.nih.gov/344956687. doi 10.1097/2.0000000000002235. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.